Good morning or good afternoon. Yeah, I do see it. This is Dr. Schievink coming in from Cedars-Sinai Medical Center in Los Angeles, and we're here for the third question and answer session for CSF Leak Week. Many thanks to Dr. Connie DeLine for setting this all up for us. Like I said, I'm a neurosurgeon, and I've had the privilege of taking care of patients with spinal fluid leaks for the last 26 years. And we are ready to take your questions. I'm also very fortunate to work with a group of physicians who have dedicated their professional lives with regard to taking care of patients with spinal fluid leaks. And particularly, I'd like to mention Dr. Frank Moser and Dr. Marcel Maya, my colleagues in the Department of Interventional Neuroradiology, and my colleagues Dr. Charles Louis and Dr. Howard Rosner from the Department of Anesthesiology. If there are any questions, then we'll get started.
We have a question from Andrea. Her question is it possible to have nerve damage if the leak has been untreated for years? And if so, can it be fixed?
Well, that is certainly possible. Obviously there are different types of leaks. Some leaks can cause a particular syndrome that looks very much like Lou Gehrig's disease or amyotrophic lateral sclerosis. That's something that's very, very rare, however, and it's caused by stretching of the nerves that go to the arms in particularly. If you are able to treat the leak early enough, then you are able to decrease the pressure or eliminate the pressure on those nerves, and at least it can make the worsening of the muscle wasting go away. And if you get it really, within, let's say, 5 or 10 years, then there's a chance of it becoming reversible.
We have another question from Monica. What is a common misconception about spontaneous intracranial hypotension?
Well, unfortunately, there are a lot of common misconceptions. I think one of the important ones is that really the great majority of patients with spontaneous intracranial hypotension are treated with 1 or 2 epidural blood patches, and they make a full recovery, and they tend to forget about those episodes. Of course, here we see mainly people who have been treated elsewhere for sometimes a very, very long time. But just going by patients who we see come in through our emergency room who have no idea that they have a spinal fluid leak. The great majority of those, when I call them years later, they forget my name, they don't know who I am, and they have sort of forgotten about that episode of their spinal fluid leak.
A question from Austin. Are there any non-invasive tests available that allows us to discern migraines from CSF headaches?
Well, there are some tests available that can, if they are positive, strongly point to a diagnosis of spontaneous intracranial hypotension. For example, a brain MRI is usually performed first, at least in this country. And if the brain MRI shows sagging of the brain, or after they administer the dye, it shows a white line around the brain, which is also known as meningeal enhancement. And it's really caused by blood vessels, veins dilating as a result of the loss of spinal fluid, then you can be very comfortable with making the diagnosis. However, and that's another common misconception, quite a few patients who have a demonstrated spinal fluid leak in their spine have a completely normal brain MRI. So if the brain MRI is normal and you still suspect the diagnosis, then there are different ways of imaging the spine. to see if we can detect a leak there. But similar to the brain MRI, spine imaging also can be completely normal in people who we know must have a spinal fluid leak. So there are a lot of uncertainties for some patients, but certainly normal imaging does not rule out the presence of a spinal fluid leak.
A question from Josh. He's taking painkillers for the headaches. He would like to know, can you do further damage by being upright more often or doing too much because of pain receptors being mostly blocked?
Well, I think one rule is that any type of activity that a person is involved in, when there's a spinal fluid leak, when that activity makes their symptoms worse, it really does not make sense to push through it, and then it's best to avoid that type of activity. What's fascinating about spontaneous intracranial hypotension is that even if symptoms have been going on for years, if not decades, that they are, in most patients at least, completely reversible, even though the symptoms have been present for a very, very long time.
A question from Jessica. What percentage of patients do you see with multiple, multi-level spontaneous leaks for whom surgery is contraindicated? And what is the overall prognosis for most of these people?
Well, another common misconception, and some of us, including myself, are responsible for that, is that multiple simultaneous leaks are commonly seen. That's actually not the case. It's actually quite rare. It's just that when a person is leaking from one location in the spinal fluid can go up and down the spine almost uninterruptedly, because the space around the dura, called the epidural spine, the epidural space, is very capacious and is like a superhighway, and the spinal fluid, or the dye, when you do a myelogram, can escape at many different levels of the spine. And 10, 15, 20 years ago, we used to think that those patients have multiple leaks. That's actually not the case. And it's really rare for there to be more than one leak at a given time.
A question from Deborah. Can high volume patching help a sagging or bulging dura caused by connective tissue problems?
Yes, it can. So some patients with spontaneous intracranial hypotension really do not have a leak, but what they have is that their dura, the membrane that covers the spinal fluid, is abnormally distensible, meaning that the elasticity of the membrane is lost and it sort of bulges out, and that has basically the same effect as a true spinal fluid leak. And epidural blood patching, particularly high volume epidural blood patching, can counteract that by causing scarring around the dura.
A question from Janelle. Follow-up. Are there any long-term or permanent effects if you choose not to fix a leak?
Well, that depends on what the symptoms are. But again, most of the time, if the leak is fixed, even if the leak has been going on for many, many years, those symptoms are still reversible.
A question from Rachel. What is the standard aftercare for a blood patch or fibrin glue patch? Why is this important?
Well, there is no standard of care for that. As a matter of fact, there's very, very little evidence-based medicine as far as blood patching is concerned. There's never been any randomized trial comparing, let's say, blood patches to bed rest or caffeine or whatnot. And certainly that's the case with the limitations that we tell patients about after epidural blood patching. Nowadays, what we tend to recommend is for a 1-month period is to try to refrain from any, particularly exertional type of activities. Try not to lift more than 10 or 15 pounds. Try not to strain when you have a bowel movement. And when you go to the beach or when you walk on the snow, try to avoid walking on soft sand or freshly fallen snow, because that causes a lot of straining on the back. But again, there's very little scientific evidence that is the right way to deal with that after an epidural blood patch. And there are some physicians, including some of my colleagues here, who like to tell patients to take those precautions for 2 months, sometimes even 3 months. And there are places around the world where patients are told just to resume normal activities after a day.
A question from Mary. Can symptoms change over time such that the positional aspect of a headache becomes less relieved upon laying down? Or could that be due to someone fluctuating between low pressure and high pressure?
Yeah, that's a really good question. And we've known that, pretty much from the beginning of spinal fluid leaks, that if the leak becomes chronic, and with that I can mean either, months or years, that oftentimes this sort of positional part of the headache gets lost over time. And the reason for that, we don't really know, but it certainly could be that the pressure, rather than staying low, actually becomes normal, and that therefore there's not so much of an orthostatic positional component anymore. But the real reason behind it is currently unknown.
A question from Rose. What would be the next imaging done if CT myelogram doesn't show a leak and a blood patch doesn't work?
Well, it depends. So if this is somebody where we really suspect a spinal fluid leak, then usually the next imaging that we perform is something that's called a digital subtraction myelogram. And that's a type of test that, at least here in the hospital I work at, is performed under general anesthesia. It's a very high resolution machine. Limit of resolution is 200 microns, and my colleagues in interventional neuroradiology use this machine to treat brain aneurysms or arteriovenous malformations in the brain. And it's really a unique way of looking at the dye as it is being injected. And it's very useful for patients who have a very rapid, a very fast leak, because you can almost always pinpoint the exact site of the spinal fluid escaping into the epidural space. But we've also discovered, and that's a discovery that was only made a few years ago, that some patients have a abnormal communication between a spinal fluid space, and that can be a little cyst, or it can just be a nerve root sleeve, and a spinal vein. So it's something that we call a CSF venous fistula. And that's usually the test that we recommend in patients who we really suspect a spinal fluid leak, if MRI myelography or sometimes CT myelography is normal.
Are you likely to recommend a blood patch nonetheless if a leak does not show on a DSM?
Well, again, it depends on the situation. So even for those patients who have a history that's compatible with a spinal fluid leak, even though all imaging is normal, we oftentimes perform 1 or 2 simultaneous epidural blood patches. And of course, the main reason for doing it is to make the symptoms go away, but it's also a little bit of a diagnostic test.
Is there harm in getting a blood patch if it turns out that there is no leak to begin with?
Yes, that's certainly possible. So we would always do that, with the individual awake, who can, tell us, or can tell the person who performs the blood patch when the pressure gets too high, or if they get any type of sciatica type symptoms. But certainly if you would do an epidural blood patch in somebody who does not have a spinal fluid leak, there's a good chance that, at least temporarily, they'll have a worse headache and worse back pain. That's almost always temporary, though.
A question from Charlie. Is it possible to have a CSF leak for 3 weeks and it heal overnight and result in high pressure headaches?
Yeah, that's possible. I've encountered that in a few patients. It's unusual, or at least it's an unusual history that people tell me, but that certainly can occur.
A question from Kay. How do you distinguish between rebound symptoms versus continued CSF leak symptoms 3 weeks post patches?
Well, typically, when somebody has a headache from a spinal fluid leak, the headache is much better when the person lays down, and it's worse when they're up and about. And then rebound high intracranial pressure is sort of the opposite. So it's a type of headache that's actually worse when the person lays down and is better when they're up and about. Now, in that kind of situation, nowadays we're pretty familiar with that scenario, and we would be able to make that diagnosis, but there probably are quite a few patients who have the same type of problem going on, but the symptoms are just not as obvious, and we would miss the diagnosis. I remember the first time that I had a patient with rebound intracranial hypertension, and this was back in 1994, I believe, and it was somebody we had operated on for a very large leak from a cyst in his spine that he had had for 8 years. And I operated on him, and then after surgery, the day after, he said, "Well, doc, my headache isn't any better. I still have a headache." Now, of course, back then, we didn't have as much knowledge as we do now. Sent the patient home, and then 6 weeks later, he called me that he had lost vision in his left eye because the pressure had built up so much that he had a hemorrhage behind his eye. And then when we talked about it in a little bit more detail, he said, well, yeah, he did still have a headache, but it was the opposite type of headache. And he actually wasn't able to sleep for all of those 6 weeks, and he had to sleep, with multiple pillows propping up his body.
A question from Denise. What percentage of CSF leakers who have been surgically repaired have a recurrence of a leak? Is that known?
Well, the last time I looked at that is quite a few years ago, and back then it seemed that there was about a 10% chance of that happening over about 10 years. But quite a few of those patients, when I talked to them, years later, is they told me that they actually never really felt 100% normal, and it probably was the same leak all along, so not really a recurrent leak.
A question from Colleen. Is it possible to drip from the nose and eyes if you have a spinal leak, or would that mean a brain leak?
Well, that's a really good question. So another misconception is that spontaneous intracranial hypotension can be caused by a spinal fluid leak, what we call at the level of the skull base. So it would be a leak where the spinal fluid leaves the body either through the nose or down the throat, sometimes through the ears. And those leaks occur, not infrequently. They can occur spontaneously. We see a lot of those patients as well. But those people do not have spontaneous intracranial hypotension. They don't have the typical imaging findings. As a matter of fact, they don't have headaches, let alone positional headaches. What happens not infrequently in people with a headache, and whether that's a headache from a spinal fluid leak or it's a headache from migraine, is that there's a reaction in the mucosa, the lining of the nose, that produces more nasal discharge. And that's actually the clear fluid that patients experience sometimes when there's a spinal fluid leak. Rarely, people have both going on at the same time, so they have a spontaneous leak through the skull base as well as a leak going on in the spine.
A question from Polly. How is it possible to have a substantial CSF leak yet be symptom-free or experience minimal symptoms?
Yes, well, clearly that's an enigma. Why would that happen? I think the reason that happens is that in the beginning, when there's a large leak, the spinal fluid escapes through the little openings along the spinal canal into the muscles and the soft tissues, into the abdomen, and there are a lot of symptoms. But over time, your body can form a membrane around that spinal fluid leak. So even though there is still a spinal fluid leak going on, the body has contained it and has thereby been able to increase the volume of the spinal fluid and thereby the pressure. So there are quite a few patients who have very substantial spinal fluid leaks, but they have no or only minimal symptoms from that.
A question from Charlie. Can you explain any relation between EDS and CSF leaks?
Yes, it's a very common association. As a matter of fact, the very first patient who I ever saw with a spinal fluid leak was somebody who was very tall and lanky and double jointed. And it's something that in our practice we see much more often than not. So the vast majority of patients who have spontaneous leaks do have an underlying what we call disorder of the connective tissues. Now, there of course are many different types, and Ehlers-Danlos syndrome type 3, the familial type, is certainly common, but most of the time we don't really know what this connective tissue disorder is. It just means that the dura, right, the lining of the spinal fluid, is more delicate in those people. So that can mean that they were born with one or more cysts along the spine, not necessarily where they're leaking from. It could just mean that, again, that the dura is more susceptible to a leak just because it's more delicate. Now, we also know that another reason for having a spinal fluid leak is that there's a little piece of calcium, a little piece of bone that might have been rubbing against the dura, or it actually might have pierced the dura, causing a leak. But that by itself is not enough to have a leak. There also must be some type of predisposition because these calcified discs are very, very common in anybody over the age of 20.
A question from Valerie. Is there a clinical difference between brain sag and cerebellar tonsillar descent?
Yes. So with brain sagging, we really talk about the whole brain falling down. And part of that is cerebellar tonsillar descent, which really just means that the very tip of the back part of the brain, called the cerebellum, is somewhat below the level of normal. On the other hand, you have to be careful because quite a few MRIs, of course, are done nowadays, and it's not an uncommon finding, at least in the radiologist report, for it to say, some cerebellar tonsillar herniation, even though it really is within the limit of normal. But when you see cerebellar tonsillar herniation together with flattening of the pons, which is part of the brainstem, or sagging of the nerves going to the eyes or the midbrain and other parts of the brain, then you can be confident that that must be from a spinal fluid leak.
A question from Michelle. What is the youngest age of a confirmed spontaneous leaker that you have treated?
Well, the youngest patient that we have treated for a spontaneous leak is a girl who started having symptoms around her second birthday, and she was able to come out here, I believe, when she was 4 or 5 years old, when the diagnosis already had been made.
A question from Kathleen. When do you patch, or when do you choose to do surgery for a leak caused by perineural cysts?
Well, that depends on several factors. The most important one is, the expectations of the person with the spinal fluid leak. So there are patients who want to do anything to avoid surgery, and we have patch patients, dozens of times, and there are patients who prefer to find a usually quicker resolution of symptoms, and I've been asked to do surgery for that in people who've never even had a blood patch done. So there's no wrong or right answer to that. Both scenarios are very reasonable, but most patients are somewhere in the middle. Certainly if I had a spontaneous spinal fluid leak, I would try certainly several epidural blood patches or glue injections before I would go ahead with surgery. I think, I've never had those procedures done, I've never had surgery, but that's what I would think for myself. But everybody is a little bit different.
A question from Rebecca. How long after a blood patch do you know you fully recovered and you do not need another blood patch, especially if you still have some symptoms, but those symptoms are not as severe?
Yeah, we don't really know the answer to that. I think for most people, however, I think sort of the 3-month period is very important. I think a lot of treatment failures occur within 3 months. Of course, most of those occur within the first month, but most patients know by the 3-month period whether or not treatment has been successful. And usually there's very few recurrences between 3 months and 1 year.
A question from Michelle. What are the success rates or expected outcomes for patients with multiple causes of intracranial hypotension?
Well, that of course depends on what the causes are. Unfortunately, we know very little about the causes of spontaneous spinal fluid leaks. But for example, the expectation for somebody who has a tear of the dura that's caused by some underlying weakness of the dura, and it's associated with a little piece of bone that has been rubbing against the dura, then the expectation of surgery is that the cure rate, and with that I mean that imaging after surgery doesn't show the leak anymore, the cure rate is very high. It's better than 95%. Now, of course, there are some patients who, even though we cannot find the leak anymore, still continue with symptoms. And that's oftentimes difficult to treat.
A question from Maria. Can a person who's had 3 blood patches be leaking intermittently if they have good days and bad days?
Yes, I think that's actually a pretty common scenario. And whether it means that it's a leak that's intermittent, right? It's there on 1 day or 2 days out of the week, or if for whatever reason the brain is able to keep up with a continuous spinal fluid leak, I think both those occurrences can happen.
We have gotten several questions about what is on the horizon for patients with CSF leaks that are not healed by patching and surgery, like stem cells or gene editing. Any ways to improve quality of dura? Is there anything on at this time?
Well, unfortunately, there's very little basic science research being conducted as far as the dura is concerned, as far as any genetic contributions to the dura is concerned. We're hoping to start a genome-wide association study that would hopefully help us to identify the one or probably the several genes that are involved in the building of the different parts of the dura, of the different fibers. And we're also hoping to develop an animal model where we can try different treatments, anything from an infusion of stem cells to just basic differences in nutrition that would hopefully be able to show us the whether or not the dura has been strengthened.
Yeah, it says broadcast enjoy.
Yeah, we've lost the signal. They can't hear you anymore.
Everyone is
All right.
on. Wait, it's 11:30. So you want to try to get signal back and then say your goodbyes. Is it on now?
No. Oh, there we go.
Okay, we're back. Okay, would you like
We're going to go on.
Okay, wait.
Is it better now?
Oh, no, it's not. Do you want to try closer to the window?
He's back.
I'm seeing now the last answer you gave.
Yeah, I'm seeing my last
See if it
answer.
comes back.
It's skipping through.
Are we back on? My apologies for this interruption. We'll take more questions if there are any more.
A question from Elizabeth. Does the presence of spinal cyst result in a higher incidence of normal brain imaging, both at onset and over time, as the body's adaptive mechanism has developed gradually over time as cysts may enlarge?
Well, the matter of fact is that spinal cysts really never, or if they do, hardly ever, enlarge after adolescence. That's really almost unheard of. There really is no good relationship between the type of leak that a person has, whether or not there are cysts involved, and whether or not we can detect abnormal brain imaging. But what also is an important fact is that cysts, particularly when they're smaller than 8 millimeters or so, are very common incidental findings. And they really do not support a diagnosis of spontaneous intracranial hypotension. And certainly the presence or absence of spinal cysts is not related to whether or not we can make a diagnosis of spontaneous intracranial hypotension.
A question from Tanya. If a blood patch is successful, does the dura heal 100% to prevent reoccurring leaks?
Well, we believe that that's the case in most patients. So recurrence after 3 months of symptoms is something that is rare. We don't really know how rare that is, but again, last time I looked at this, but it's been a few years ago, it looked like it happened about in 1 out of 10 patients over 10 years from the onset of the symptoms of their leak.
Question from Farhana. ICP monitoring, which is commonly done and encouraged to do in the UK to measure the ICP.
We know that spinal fluid leaks cause symptoms not so much by there being low pressure, but it's really low volume of spinal fluid. So actually about half of the time in patients who have a documented spinal fluid leak, the pressure is normal when we measure that. And there is some risk to intracranial pressure monitoring. So, for example, in our practice, we never use intracranial pressure monitoring for the diagnosis of spontaneous intracranial hypotension. I really only use it in patients who have had multiple shunt surgeries, and we need to know exactly where the pressure is.
A question from Denise. Can a chronic leaker continue to suffer symptoms even after having CSF leak repaired? Is this damage done to the nerves and brains from long-term leaking?
Unfortunately, we know very little about patients who have had a documented leak and they've had treatment, and whether that's an epidural blood patch or bed rest or an injection of glue or surgery, and no longer have a leak visible on our imaging, yet the patient still has symptoms. Again, that's a scenario that luckily is not very common, but it does occur, and that's something that oftentimes is difficult to treat.
A question from Elizabeth. What is and what causes a direct fistula between the intrathecal space and the epidural veins?
Well, at surgery, I've really encountered two different types of these CSF venous fistulas. The first type, which I call type 1, is a direct vein connection to the dura. So there's it almost looks a little bit like a leech that's attached to the dura. And even though it's blue in appearance, when I cut it with micro scissors, there's a combination of blood and spinal fluid coming out, with 90% of it being spinal fluid. I usually treat that just by placing a little titanium clip on this venous structure, or we can cauterize it with micro instruments. The other type that I call type 2 is where there's a little tangle of blood vessels that surrounds the dura where the nerve comes out of the spinal cord. And that we usually treat with cauterization with small microbipolars.
A question from Elizabeth. Can you update us on any progress with PRP patching at Cedars?
Well, we have certainly used PRP patching here, and we continue to do so. Again, there's no randomized trial that's going on comparing blood patches to PRP. There have been some patients who have had very good outcome from PRP blood patching, even though they did not react well to multiple epidural blood patches. And the opposite has happened. One of the problems is that we generally only would think about doing PRP in people who have failed epidural blood patching, so that really skews the results. Also, it's difficult to obtain a large volume of PRP compared to using the person's own blood for a regular epidural blood patch.
A question from Mackenzie. How long should we wait after being sealed before working out?
Well, I think after treatment for a leak, it's important to consider those precautions that we talked about a little bit, so no heavy lifting, nothing too exertional, and I think it makes sense to limit yourself for about a month. Then I usually tell people to resume really any type of activity that they like doing, but I think it's important to really build up to that activity, and if something doesn't feel right, then don't push through it. Just stop doing it and try it again in a few weeks. And maybe we'll take one more question, and then we'll wrap it up for this Friday afternoon.
A question from Elizabeth, does a spontaneous leak increase the risk of developing a subdural hematoma?
Subdural hematomas are very common in people with spontaneous spinal fluid leaks, and they're certainly more common compared to people who have a traumatic spinal fluid leak from, let's say, lumbar puncture. Fortunately, the vast majority of these subdural hematomas can be managed conservatively, meaning that the vast majority of people do not need brain surgery to evacuate, to remove these subdural hematomas. But we see it about, one out of 4, 1 out of 3 people with spontaneous leaks do have subdural hematomas. One more question.
A question from Tanya. What is the typical amount of blood used to patch a spontaneous leak?
Well, that can really vary. So usually what we do here is that once the needles are placed in the epidural space and it's been confirmed with an injection of a small volume of contrast dye, is that we make sure that the patient is fully awake, and then we start the infusion of blood. And we usually continue that unless the patient starts having back pain, sciatic pain down their legs, or when we push in the blood, the pressure really builds, and then we usually stop. And we have treated patients successfully with as little as 3 milliliters of blood, and we've used as much as 135 milliliters of blood. Well, I enjoyed this session, and I think we'll be doing more of these, maybe sometime later this year. I also would like to point out that we will be having a intracranial hypotension symposium here in Los Angeles in October, on Saturday, October 14th. And this symposium is open for both physicians, healthcare providers, as well as patients. I hope everybody will have a safe weekend. Thank you.